Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your co-host, Dr. Brittany Scruggs.
And I'm your co-host, Dr. Eric Bothan. We are here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today, we were again joined by one of our valued Mayo Clinic glaucoma specialists, Dr. Arthur Sitt. Tune in to hear about the importance of ocular mechanics in the field of glaucoma and Dr. Sitt's career research surrounding IOP fluctuations.
Dr. Arthur Sitt is professor, research chair, and glaucoma fellowship director in the Department of Ophthalmology at the Mayo Clinic. For almost 2 decades, Dr. Sitt's research has focused on the mechanisms that regulate intraocular pressure and contribute to glaucoma, with a particular focus on aqueous humor dynamics and ocular biomechanics. His work has led to the development of innovative, non-invasive technologies to measure episcleral venous pressure and assess ocular tissue biomechanics in vivo. Last year, we invited Dr. Sitt on the podcast for a Glaucoma Journal Club. One of the articles studied IOP fluctuations and the visual field progression rates in the United Kingdom glaucoma treatment study. We realized how much more there is to unpack on this topic, and we asked Dr. Sitt to come back to share his expertise and research. Welcome, Dr. Sitt.
Thank you. It's really a pleasure to be back here and talking about one of my passion projects, and that is IOP fluctuation. So I'm looking forward to our discussion.
So in clinic, we check pressure, right? Every time, one pressure. But you've really shown us that there's variability, like there's normal variability. Every patient has a range of pressures. So maybe walk us through, us and the listeners, of what is a normal variation. If we check the pressure in the morning and the midday and then afternoon and in the middle of the night, what would we see in that range?
Absolutely. I think the short answer is you'll see something different. IOP is always varying. It's very much like blood pressure. It's always varying, and if you take a pressure at one time and take the pressure again a couple of minutes later, it's going to be different. And there is a circadian pattern where IOP tends to be higher early in the morning and decreases over the course of the day. So that's lower in the late afternoon, early evening. But then when you lie down and go to sleep, that change in body position causes it to go up while you're sleeping. So there's a clear circadian pattern to the IOP. But within that circadian pattern, there's just constant variations with pretty much everything that we do.
When I trained, I remember we'd diurnal. We kind of track pressures throughout the day, every hour.
That was part of call.
It was.
These are the patients you have to check at 11 p.m.
The topic today is about IOP fluctuations and the what happens in the eye to lead to fluctuations or to dampen them. But why don't we do that as much?
That's a good question, because when I started practice, we did do that more frequently. And the reason is that it does give us a little bit of information about variability, but it doesn't tell us enough to justify the expense and the inconvenience to our patients. There have been some nice studies, particularly from Tony Riolini at West Virginia University, looking at the repeatability of diurnal curves, and they're just not repeatable. So one diurnal curve doesn't mean that it's going to be equivalent to another diurnal curve. So their values are I wouldn't say they're useless, but their value is limited.
So I'm very interested in the positioning part. I mean, as a retina specialist, we make patients do strange positions all the time, right? But we have a lot of questions of like, on the operative eye, should I lie on that side or lie away from the side? And you said being on your back increases the pressure. So if someone has advancing glaucoma and they're worsening, maybe they have normal tension glaucoma, do you ask them to sleep on their side or even propped up a little bit? Like, what is your recommendation?
And that's a great question. And that's an extremely common question from patients and even from ophthalmologists, because we know that IOP changes with body position. And if you can do some really crazy positions to significantly increase your pressure. I don't know if you're a yoga practitioner, but if you were to stand on your head in a yoga position, that will double your pressure. We know that pretty much any body position other than sitting upright with your neck in a neutral position is going to have a higher pressure than what we measure in the clinic. And so the question that we often get asked is, if your pressure is lower when you're sitting upright or with your head elevated? Should I sleep like that? And the bottom line is that we don't have any evidence that that is going to be helpful. In fact, we did a study last year looking at perfusion pressure, so the blood pressure in the eye and the optic nerve. And we can't measure that directly, but there are ways to estimate that. And it turns out that the perfusion pressure is better when you're lying down than when you're sitting upright. So it may actually be beneficial lying down, and if you have glaucoma and have susceptible optic nerves.
So pressure's not everything.
The eye pressure is not everything.
Right.
There are other pressures. There's blood pressure, and there's also the pressure in the brain, and really those three pressures interact, and are all factors in what determine whether someone has glaucoma and whether their disease progresses or not.
Brittany, you're a retina specialist, and certainly there are retinal conditions that present situations in which patients are advised not to perform certain sports activities or certain activities that are felt to put their retina in greater risk. So even though you said that there's not well understood behavioral changes over which side to lay down on and what to do from a glaucoma perspective, are there currently just a big picture, and we're going to get into your research next, but big picture behavioral things you ask them not to do?
Yeah. So I think for someone with severe glaucoma, I do recommend not standing on their head, because there is such a drastic increase in the pressure, and generally that's an avoidable activity. But sleeping is not an avoidable activity. Everyone has to sleep. And physiologically, it is a normal physiological position. So
glaucoma would be career-ending for a trapeze artist or something.
I think there would be some caution that needs to be taken there.
So it's tricky. So patients come in, maybe they're advancing their glaucoma. There are so many questions that could be asked, right? Are you hanging like a bat for 5 hours a day? It's not a question I commonly ask patients. So how do you spend the chair time making sure you address all of the risk factors?
Yeah. So I think another common question is does it matter what side you sleep on? Because as you know, a lot of glaucoma patients have asymmetric disease. And there are studies that show that if you sleep on one side preferentially, the dependent eye, so the lower eye, tends to have worse disease. And there's a couple possible reasons for that. One is that the pressure is a little bit higher in that dependent eye just from gravity. But it's also possible, and I really caution patients against this, is if they're pushing the pillow into their face, that can cause your eye pressure to go over 100 or more.
Okay.
So I really caution them about having pressure against the eye from something external.
So
like
you really
pillow.
do talk about sleep positioning and sleep practices with most of your patients.
Well, particularly if they have asymmetric disease.
Understood.
So in preparing for this, I had the opportunity, Brittany and I did a look back at your research, and you've spent almost 2 decades in a stepwise way looking at this topic, IOP fluctuations, and it's way more complicated than just laying down or sitting up or being a trapeze artist. You've really defined what's happened, continue to define it even now, what's happening in the eye in terms of ocular biomechanics and fluid flow. You have even described glaucoma in terms of repetitive strain. So give us a kind of a 2,000-foot view over what you realized early on as a glaucoma specialist that we needed to understand more, and what your lab and what your research has been focusing on, and then we're going to talk about specifics.
Absolutely. So I think from the earliest point, I think we all recognized from when we were training, when we were residents, if you checked the pressure and your attending came in 5 minutes later and checked the pressure again, they're going to be different. And that's not because of measurement error necessarily. That's because pressures do vary; they fluctuate, and we need to understand that. And again, it's very much like blood pressure. We know that it fluctuates, and understanding that is very important. I was fortunate enough to I've done a fellowship with Bob Weidenrad in San Diego, where they did 24-hour studies at a sleep lab. So that also influenced my career direction, looking at what happens over 24-hour periods, how different treatments have different levels of efficacy at nighttime compared to the daytime, and those are important considerations that really made me realize we have to understand what IOP is doing a lot better than we did.
And along the way, you've understood that potentially it's less about the pressure and potentially more about repetitive strain. Tell us about that terminology and what's your thought behind it?
Yeah, so I throw that out, not to say that it's a definitive answer, but more as something to provoke some thought about the importance of IOP fluctuations. And we all kind of know what repetitive strain injuries are. We all are using computers every day and clicking on a mouse thousands of times a day, so we understand what the toll of repetitive motions can be. And the eye certainly undergoes those repetitive motions through variations in intraocular pressure. And we and others have looked at the importance of this to glaucoma. And there is definitely data that is very suspicious, very thought-provoking.
So let's talk a little bit about equations. So the modified Goldman equation, and just in general, when we're thinking about all of these different pressures, not just eye pressure, but perfusion pressure, and how in the lab and in your research do you study this? So if we talk about episcleral venous pressure, maybe explain to our listeners, how do you actually study that?
Sure. So let's talk about the modified Goldman equation, and I'm an engineer by training, so I love the mathematics. I know that a lot of my colleagues don't, but the modified Goldman equation relates intraocular pressure to a number of parameters. So episcleral venous pressure, outflow facility, uvoscleral flow rate, and aqueous humor production rate. And so it gives us a way to model how all these factors contribute to IOP and how difficult it is for the fluid that's produced in the eye to leave the eye. So to model it properly, we have to be able to measure each of those components. So we can measure outflow facility using tomography, and that's a technique that goes back to Morton Grant in the 1950s, and certainly been updated, and we continue to update it to try to make it more reliable. The aqueous humor production rate, that was measuring that was one of the great contributions and breakthroughs from Richard Brubaker, who was, of course, one of the great glaucoma specialists at Mayo Clinic, and inspired me to follow on that path. And he developed the technique of fluorophotometry to measure how, if you place a depot of fluorescein in the eye with eye drops, how quickly that can be cleared away and give us a measurement of how much aqueous humor is being produced. And then episcleral venous pressure was one of the contributions that our lab made. It was a difficult measurement because you have to place a clear balloon against the surface of the eye, against one of the episcleral veins, and increase the pressure on that balloon until you see it collapse. But the tricky part is the episcleral venous pressure correlates with when the vein just starts to collapse. So the only way that you can find that point is by taking a video, synchronizing it with all the pressure measurements, and determining that point when it just starts to collapse. And then uvoscleral flow rate is where that equation comes in, the modified Goldman equation, because we have to calculate it from all the other parameters.
So being able to understand fluid change and flow, you've used these parameters to study position, activity, and how ocular biomechanics work. What were, looking back, I think one of the early ones was about position, based on what we started this podcast talking about laying down. What was your early sense over what you could do with these mechanical tools to measure flow, and what were you finding in terms of position and variability through the day for patients? Absolutely.
So we knew there has to be a reason that pressure changes with body position. And again, Richard Brubaker did some early work looking at whether flow rate changes with body position. He didn't really find that had an effect, or certainly not a significant effect that would explain the changes in pressure. So we knew it had to be something else, and we went back to the Goldman equation and looked at the other parameters. So we looked at outflow facility and found that that didn't change with body position. And then, after we developed our technique for measuring episcleral venous pressure, we could measure that, and we found that it did increase significantly with body position, and almost to the same degree as IOP. And from that, we surmised that the changes in IOP that we see due to body position were probably due changes in EVP.
Did you see that coming, or was that kind of your first thought of where it would come from, or was it in question all along?
It was in question because we there's so many changes that happen physiologically that it's hard to predict what's going to happen. In hindsight, it probably makes sense because you're lying down and the pressure goes up in the veins.
Yeah.
But
Stand on your head all the more.
Exactly. But when you're first starting to investigate it, it wasn't obvious to us.
So with patients, obviously there are a lot of confounders, right? What activities they do, whether or not they're giving blood every 56 days, right? Are they anemic? There are a lot of systemic things that also impact whether or not they're developing glaucoma. But there has to be something that's making the optic nerve susceptible. There can be patients in 2 rooms, one at 25 pressure and they have no problems, and one potentially they're worsening at a pressure of 14, right? And so practically, can you walk us through what are some ways that you can determine, is this optic nerve susceptible to pressures, maybe even lower pressures than we would call?
So clinically, unfortunately, that is something that we struggle with because there's no really good way of saying this is a susceptible nerve. And that's why surveillance in glaucoma is so important to determine if there's any disease progression. I think there are a lot of things that, from a research standpoint, that we are interested in. One is obviously fluctuations in IOP. Is it the fluctuations themselves, which is something that I've posited, or is it just because it's a lot higher outside of clinic than what we're measuring? We don't know. And then it also goes to another area that you touched on briefly, ocular biomechanics. Is there just something about those nerves that are particularly susceptible? And you're absolutely right. There's most patients who have so-called elevated intraocular pressure don't get glaucoma, whereas as many as half of our patients have glaucoma at normal pressures. And if you look at other populations around the world, particularly in Asia, in Japan and Korea, up to 90% of the patients have a normal tension glaucoma. So there is something that makes those nerves particularly susceptible to even a normal pressure.
I know you've also talked about how pressure changes throughout the day. And some of your prior work has gone into the circadian rhythms. And what did you find in that respect? Did you find in terms of components that's changing throughout the day?
Yeah, no, absolutely, and that was also something where we didn't know what was going to happen. we knew that aqueous humor production drops by about half at nighttime, and that was work from Richard Brubaker. But if you think about it, if you're producing only half the amount of fluid at nighttime, then if everything else stayed the same, you would expect the pressure to drop by about half, and that doesn't happen. That pressure actually goes up. At least when you take into account body position. So we really didn't know what we were going to find, and so we did a couple of studies looking at changes in aqueous humor dynamics from daytime to nighttime, and what we found is that there's a little bit of a decrease in outflow facility, but there's a huge decrease in uveoscleral flow. The uveoscleral pathway, and just to remind our listeners, is the alternate pathway for aqueous humor outflow. Most of the fluid goes through the trabecular meshwork into the episcleral veins, but then there's a secondary pathway, the uveoscleral pathway, that goes across the iris root into the supraciliary space. And that pathway essentially shuts down at nighttime, and those factors, those different changes, combine to essentially keep pressure stable at nighttime when you eliminate body position changes.
So again, I had a question regarding treatment on that regard, but go ahead.
No, you can finish.
In that, with the awareness of these changes and understanding the reason behind the change, how does it affect your current dosing of eye drops for patients to lower pressure? You've talked about not using timolol at night with us before, but just for many of you listening, probably prescribing Cosap twice a day or timolol once a day or twice a day or whatever they might be. But what do you advise people treating their patients for glaucoma medically as to whether or not morning, afternoon, evening should be in their normal habit or changed?
Yeah, so in general, aqueous humor suppressants don't work well at nighttime because the aqueous humor production rates are rated at a very low basal level. So things like timolol, brimonidine don't work at all at night, as far as we can tell. Carbonic anhydrase inhibitors do work, but to a much lesser degree. So things that enhance uveal scleral flow, so the prostaglandin analogs seem to work quite well, and that makes sense because uveal scleral flow is nearly shut down at nighttime in a normal eye. And then things that improve outflow facility definitely work at nighttime. So it is a matter of balancing the different treatments and to give the best effect over 24 hours, and then avoiding those things that don't work, like timolol and brimonidine. There's really no point putting it in at bedtime because it's not going to do anything.
So to add to that, in addition to the eye pressure, we've also talked about perfusion pressure. And do you recommend specifically blood pressure medications to be held after like 5 p.m. just to avoid that nocturnal hypotension?
And that's a tricky question because, as you know, our internal medicine colleagues and cardiology colleagues are very concerned about blood pressure at nighttime, and I think we obviously want our patients to be alive, and so managing systemic hypertension is very important. But if I have a patient who seems to be progressing despite apparently well-controlled pressures, then I definitely will address that and address it with their internal medicine or cardiology providers.
But potentially they could do their blood pressure medication earlier in the night and not 11 p.m.
Right.
Right.
Absolutely.
Right when things are starting to decrease in terms of perfusion. So I was going to pivot to the retina part of this, if that's okay. So when I was thinking about what specialty I wanted to do, one question that one of my mentors asked was, well, are you a buckler? Like, that was the main question. I was like, well, yes, I love buckles. Like, that's my favorite thing. And that's still my favorite surgery to do. A primary buckle, it's hard to beat that. So I love your research because it tells me I should do more buckles. So can you just share with us vitrectomy versus buckle, the glaucoma risk, and specifically how it relates to IOP fluctuations?
Sure. So we did a study looking at the risk of glaucoma after vitreoretinal surgery and compared vitrectomy versus vitbuckle versus buckle. And I will confess to you, we started that study because I really don't like performing glaucoma surgery after someone's had a buckle.
I know.
And so I was really hoping that I could show that buckles were bad and we could get rid of buckles. But that study really in particular showed me the importance of keeping an open mind when you're doing research and not having a predetermined outcome that you're trying to reach. Because we found the complete opposite. We found that patients who had vitrectomy or vitrectomy and buckle were at significantly increased risk of glaucoma. And that was consistent with work that had been done in the past, particularly Stanley Chang. But what really shocked us was that our scleral buckle cohort had none of them developed glaucoma within our study period. And that was really surprising to us, and so we tried to understand why that was the reason. So then we did a subsequent study looking at some of the effects of scleral buckles on aqueous hemodynamics and also the ocular biomechanics of the eye. And what we found is it doesn't affect the aqueous hemodynamics, but it does significantly decrease the ocular rigidity of the eye.
Which it seems like it would be the opposite. When you tighten your belt, everything gets tighter. So explain.
Yeah. So physiologically, what we saw with that, first of all, is that if you lie down, your pressure goes up. But we found that patients who had scleral buckles, when you lie down, the pressure went up to a much lesser degree. So there was a real physiologic effect. And then, so why it would decrease ocular rigidity? We think it's because when you put a buckle on, you're actually decreasing the volume of the eye. Not immediately. I mean, when you first put it on, you cause the pressure to go really high because you're just squeezing the eye. But eventually, as it equilibrates, the overall volume of the eye is slightly less. And so when you have, so pressure goes up when the volume of the eye goes up. So when you have that buckle on and you increase the volume of the eye, you don't have to stretch out the entire sclera. The only thing you have to stretch out is the buckle itself. And that requires less energy than stretching the entire sclera. And so you actually end up with a smaller change in pressure for a given change in volume.
So for those of us who do a lot of vitrectomies, and vitrectomies are unavoidable, right? Detachments, macular holes, peels. What should we quote our patients of that risk of glaucoma? And besides the steroid response in the post-op period, but like long-term glaucoma risk.
Right. So the study that we did, and it showed that it was probably about a 5 to 10-fold increase in the long-term risk of glaucoma. I think there are some complexities there because these are eyes that might have had other risk factors for glaucoma as well. I certainly wouldn't tell a patient that they're definitely going to get glaucoma, but it would be they would need much closer surveillance for glaucoma long term.
And can you walk us through the mechanism of what about removing the vitreous leads to that increased susceptibility?
Yeah, well, that wasn't any research that we did, but there are others who have looked into that mechanism. Again, Stanley Chang, but also some work at WashU, it seems to remove a barrier to oxygen-free radicals. So there is an increase in oxygen tension adjacent to the nerve, and also even in the trabecular meshwork, there's an increase in oxygen tension and free radicals that potentially are causing damage and increasing pressure and maybe even impacting the optic nerve directly.
You talk about the size of the eye making a difference in volume, affecting how the eye responds to pressure. You and I have talked about the ocular biomechanics of myopia in the past, but has this work helped you? Do you look at eyes that are a minus 29 versus eyes that are they're axial length of 29 versus axial length 22? Just understanding volume differences, scleral rigidity differences, understanding that the whole world is getting more myopic. What does it make you think in terms of their increased glaucoma risk or not?
Yeah, so myopia, especially high myopia, clearly is a risk for glaucoma, and that's been shown repeatedly from population-based studies. The reason probably is that if you have a larger vessel, and the eye is a pressure vessel, if you have a larger vessel, if you were to look at the stress in the walls of that vessel at a given pressure, the larger the vessel is, the greater the stress. And so you need stronger tissues to support the same pressure, the larger the eye is. And I think if you're highly myopic, then you just need a lot stronger tissues to support pressure, and that's why these patients are much more susceptible to developing glaucoma.
And patients that have, because I presume that the most important rigidity, structural integrity, scleral components to that is around the nerve head. The more flexible, malleable, bendable, deformable the nerve head would be, the more the glaucoma concerns would be. So in just thinking about patients with staphyloma or other posterior scleral abnormalities, does that reflect, what are your thoughts in terms of ocular biomechanics for that group of people?
Absolutely. So I'll back up a little bit and say that that's also been an area of a significant interest to us. So and we knew that it wasn't good enough to look at the whole eye because it's not necessarily uniform, as we know. And so Xiaoming Zhang, who's a colleague of mine, who's an engineer in the Department of Radiology here at Mayo Clinic, we've been using a technique called ultrasound vibroelastography for probably close to more than a decade now to try to understand the biomechanics in glaucoma and in ophthalmology diseases in general. And what we found is that in patients who have normal tension glaucoma, and normal tension glaucoma is kind of a perfect cohort to study ocular biomechanics because we know that the ocular biomechanics changes if the pressure goes up. So you can't compare glaucoma and normal patients necessarily. We also know that glaucoma medications can change the biomechanics. So if you give them prostaglandins, that changes the biomechanics. So you can't compare treated glaucoma patients with normal patients necessarily. But normal tension glaucoma, you can because they have the same pressure as normal patients, and they're not on any medication until we start them on medication. So we looked at a group of patients like that and used this technique, ultrasound vibroelastography, and what we found is that normal tension glaucoma patients had greater stiffness in their scleras and greater stiffness in the optic nerve head, and so that again goes back to the idea of that increases fluctuations. So that was very intriguing to us. We haven't studied these special cases that you mentioned, like posterior staphylomas. But those are probably going to have very altered biomechanics as well, just because you're changing the shape. And again, if you think of the eye as a pressure vessel, if you take your gas cylinder at home for your barbecue and put a giant dent in it, it's not going to be as strong.
You bet. You bet.
All right. One question just out of curiosity. So a lot of our patients are musicians and they blow trumpet all day, every day, or, saxophone. What are our recommendations for patients, especially if they're advancing in their glaucoma?
That's a tough one. So Doug Johnson, who was my predecessor here, again, one of the great glaucoma specialists at Mayo Clinic, actually looked at that, believe it or not, and he measured the pressure in wind instrument players before and during use of a wind instrument, and they found that IOP really goes up very high when you're blowing into a wind instrument. So the tricky part is it's not an easy thing to avoid. It's not like you can do a lot of yoga without standing on your head, but if you're playing an instrument, and in particular if it's your livelihood, you can't really stop that. Mm-hmm. So I would say that in those patients, we just need to do the best we can to stabilize their pressures, and the way that we stabilize their pressures is with the appropriate treatment for glaucoma. Mm-hmm. And the ones that minimize IOP fluctuations are the ones that improve outflow facility, mm-hmm. Or reduce the rigidity of the eye.
Yeah, that makes a lot of sense. Can you speak to home monitoring and sensors and implantable IOP devices and these systems that patients can rent? I mean, what's being recommended by glaucoma specialists these days?
Absolutely, I think we're at a really exciting time because we're kind of at the point where diabetes treatment was for in the 80s and 90s when home monitoring was just starting to become available. I think we're at that point where home monitoring of intraocular pressure is becoming a reality. And there are some devices on the market already for home monitoring. One is the iCare Home. That is a device that patients can measure their own pressure periodically very similar to the rebound tonometers that we use in clinic. And that definitely can give us useful information about what happens outside of clinic hours. And I do recommend that to some patients, particularly patients who, again, have seemingly well-controlled pressures and they just seem to be getting worse, or patients who I know have low-tension glaucoma and are at particular risk for fluctuations or in high pressures outside of clinic. And you know, sometimes you'll see some very interesting things, and you'll see that for some reason, you know, these patients are really spiking late in the afternoon when I'm not seeing them, or there's periods of time early in the morning or late at night where I wouldn't have expected to see such a high pressure. So it can be very helpful there. What that doesn't cover is it doesn't cover sleep, and there has been a lot of work suggesting that those sleep hours and the transition from wake to sleep may be really important in glaucoma risk. And so that's kind of the next phase of IOP continuous monitoring with implantable pressure sensors, where someone can have a tiny little chip with a pressure sensor in the eye and truly get continuous measurements throughout the 24-hour period, throughout their lifetime, really, while they have that implant in place.
And how is that placed? Can you walk
So
us through that?
there's different devices that have been under development. There's one that was developed for sulcus placement, and there's a similar there's a derivative of that was meant for suprachoroidal placement under the sclera. There's another one that's much smaller, which goes through the pars plana, and is just injected through the sclera and stays anchored to the sclera. There's different options. You know, the one with the pars plana treatment is the one that seems to be most exciting because it also has a little battery attached to it, so it can truly record continuously and not need periodic measurements from the patient. But you know, I think we're at an exciting time, and people have talked about these things for many years, but I think we're really at that point where we're going to start to see these in clinical practice in the next 5 years or so.
It's remarkable to think about all the surgical options, improvements, medication improvements in the field of glaucoma, and now monitoring improvements as you've studied and are part of in the discussion. Thank you for sharing again your expertise and your wisdom in this field and sharing this time on our podcast.
Yeah, I agree. I learned a lot. Thank you.
Thank you again. It's my pleasure to be here.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website, YouTube, or on most podcast platforms.
Thank you for listening, and we definitely look forward to sharing more on our next podcast.